So, welcome all of you for this webinar. Every bariatric procedure has its pros and cons. As a result, various weight loss procedures have been developed and have been refined over the years. Today, there is a wide variety to choose from. I would say the procedures are still evolving, and every year a new procedure comes into the practice. As far as bariatric surgery is concerned, the longest follow-up data we have is obviously from the Stampede trial. Now the problem is when we have too many procedures, the confusion starts. And the whole agenda or the purpose of this meeting is to fill the gap between choosing the optimal procedure, whether it's endobariatrics or a laparoscopic bariatric surgery. With this, I would like to introduce our esteemed panelists and speakers. Dr. Omar is a former MIS and bariatric fellow from Mayo Clinic, and presently he is a full-time bariatric surgeon at Mayo Clinic, and he's an active member of ASMBS and has published many peer-reviewed articles in prestigious scientific journals. He is an editor-in-chief of IBC newsletter, which has already endorsed our meeting. Then we have Dr. Professor Kamal Mahawar. He is a consultant general and a bariatric surgeon from Sunderland Royal Hospital, UK. And he has also published many articles, and every month I see not less than 2 or 3 papers publishing from his end. And I really appreciate the effort he's taken. And he's an associate editor of Obesity Surgery and Clinical Obesity Journal. And surprisingly, I would like to mention here, he is also a writer of 2 books. One of them is Ethical Doctor, and another one is Fight with Fat, which are really doing great in India. Our next expert is Dr. Huang, and he is my mentor, and he's been my teacher for many years. And he's from Taiwan. He'll be joining us soon. And he is the person who is behind the concept of sleeve plus procedure and has performed many first-time surgeries like single incision Roux-en-Y gastric bypass for the first time in world. He was the one who performed it. And also I would like to thank different societies before we begin, like our own Aussie, ELSA, SGEI, IBC and IAGS for endorsing our meeting. Now I will pass it on to my colleague Dr. Rakesh, who is also a very well-known endobariatric specialist, and he's a colleague in AIG Hospital. He'll introduce the endobariatric part, and then we will start the meeting. Over to you.
Great. Thanks, Abhishek. So basically, when the idea cropped up of the guidelines in for the bariatric surgery and bariatric endoscopy, so I think the bariatric endoscopists will agree, except for the recent 2-3 days before guidelines published by the Brazilian group, there are not many consensus, and it's very difficult to put on this topic. So when Abhishek told, let's do this, then I told the only person who can do this consensus or kind of frame it and then tell to the world is Barham. So that's the reason why I touched base Barham, and he was kind enough to agree. And from, of course, the bariatric surgery point of view, I think pretty much you have certain guidelines which are being framed. So to introduce Barham, again, I don't think he needs any much introduction. He's basically my mentor and my guide, a very good real friend also. And Barham is basically professor of medicine and also the director of advanced endoscopy at Mayo Clinic, Rochester. And he's also professor of gastroenterology. And he's got many publications, so I mean, it will be short of time to name around. And what I have seen with Barham from past a decade around is he's so innovative, and then he's thrive for getting new devices in the field of endobariatrics is commendable. And I am fortunate enough to work with him on a couple of new innovations which are in the pipeline, and hopefully we will give good answer for the obesity and diabetes from the endoscopic point of view in the near future. And coming to the experts, when it was thought of, then I thought, if you ask me from the last 2-3 years in the field of bariatric endoscopy, the most prolific writer, the number of papers are from one person, who is Professor Gontran Lopez Nava, another good friend of mine from Spain, Madrid, and he has got a lot of innovative work being done at his unit. And of late, Barham, I think we have to learn from Gontran that the way he is publishing with his team, So every third, fourth month, I see one article being published in one of these obesity journals across. So that's the reason why I requested Gotran, and he was kind enough to accept my invitation. So with this introductory note, so I request Barham to start the first talk on the bariatric endoscopy, and I would say probably current guidelines which are apt in each procedure and what are the limitations or kind of a consensus what he can tell to the bariatric endoscopy folks as well as bariatric surgeons. Over to you, Barham.
Thank you, Rakesh. Thank you, colleagues. It's a pleasure to join you this morning and talk about this important topic. I'm just going to pull my slides. So the topic assigned to me this morning is to talk about bariatric and metabolic procedure, choosing the optimal from the perspective of endobariatrics. As you all know, endobariatrics is a field in its infancy. It's growing with multiple new procedures and techniques targeting different parts of the GI tract. So I will give you my collective wisdom on the topic, but this is likely an evolving topic with changing parameters. This is my procedural disclosures. I'm a therapeutic advanced endoscopist, so bariatric is not my only practice, but out of my bariatric practice, 40% of my practice is revision of bariatric procedures, mostly bariatric surgeries and complications. 40% is endoscopic sleeve gastroplasty, 10% is investigational new innovations and pipeline procedures, and 10% intragastric balloons. So rather than saying what's the indication for what procedure or where should this procedure compete with the other, I think the disease of excess adiposity, or what's referred to commonly as obesity, is a spectrum with varying risks depending on the profile of the patient. So we really need a spectrum of interventions that goes from lifestyle modifications, including anti-obesity medications, endoscopic or metabolic bariatric endoscopy, and bariatric surgery. Where you fit in the spectrum initially should be governed by the severity of the disease, and this is a study published in the New England Journal of Medicine a few years back that looked at the relative mortality risks associated with different cutoffs of body mass index. Notice that this is a Western population, so it's mostly white Caucasians, but in this population, you could see that the risks start exponentially increasing at BMI above 27. And this is a cohort. So the BMI 27 to 40, a cohort that has not been effectively targeted by bariatric surgery, and they have severe enough disease that lifestyle modification alone or pharmacotherapies have not been enough to address this population. So rather than saying which procedure for what patient, I think we have a huge spectrum that we need to fill as the case has been in the field of cardiovascular medicine, where there is a minimally invasive option between medical and surgical management of coronary vascular disease, such as coronary stenting. Now, given that this is a talk that involves a lot of our colleagues in Asia and China, it's important to emphasize this same curve does not apply for different ethnicities. And this is published in the Annals of Internal Medicine that looked at the same question, which is BMI cutoffs and prevalence of obesity comorbidities, especially cardiovascular disease. Well, you could see that the dotted graph below is the Western population, and the solid graph on top is South Asians. And you could see at the same BMI, for example, BMI of 20 or 19.6, the relative risks in a white Caucasian population is less than 10%. It triples in an Asian population in a BMI that's considered normal. And why is that? Is that because BMI is a very poor surrogate for the disease, and we have a clear entity that is known as TOFI, or thin outside and fat inside. What does that mean? It means here, if you look at the graph on the left, these are two individuals, same age, same gender, same BMI. They had a scan of their body fat deposits. You could see that subcutaneous fat is quite similar. What's different is the visceral fat. In that individual who is metabolically diseased, it's about 6 liters of internal fats versus this individual with the same body mass index at 1.65 liters. So obviously, lipodystrophy or different distribution of visceral fat is a critical component of the disease of obesity that we have been neglecting, and it affects Asians and Chinese in a higher percentage than it does Western population. That's why the cutoffs for BMI should be different in these populations. So what's the goals? And it's not about weight loss. It's about improving insulin resistance. It's about decreasing excess visceral adiposity. It's about decreasing inflammation, restoring mitochondrial function, and autophagy. Weight loss seems to be a very good way to hit multiple of these targets, but also there seems to be weight-independent pathways that you could selectively target as well. Just to emphasize the importance of weight loss, this is the Look Ahead trial. It's probably one of the largest NIH-sponsored trial that followed 5,000 individuals with body mass index greater than 25 and type 2 diabetes. They randomized them to an intensive lifestyle intervention with weekly group counseling for the first 6 months, then decreased frequency. They had them on a restrictive caloric diet between 12 to 1800 and 175 minutes of moderate intensity physical activity versus the control had regular diabetes support and education. Now, with this trial, you could see that the intense lifestyle intervention group did lose significantly more weight than the control. And this, the percentage who achieved more than 10% weight loss is only 20%. But this 20% did correlate with significant improvement in hemoglobin A1C. You could see that the threshold where A1C significantly starts improving is with body mass index weight loss that starts above 5% and goes up to 15%. Change in fasting glucose also significantly improved, as well as the blood pressure profile and hypertriglyceridemia, HDL, and LDL. So a total body weight loss in the neighborhood of 7 to 10% is sufficient to get most of the cardiovascular and metabolic consequences of excess adiposity to resolve. But the problem is only the minority of individuals subjected to even intense lifestyle intervention could reach these thresholds. And that's why we need procedures and surgeries to allow the majority of patients to get there. So 5% total body weight loss gives you improvement in cardiovascular risks. 10% total body weight loss gives you improvement in cardiovascular risks, diabetes, cardiovascular outcomes, and regression of fibrosis, and should be the goal of managing the disease of obesity. Now, does how you get to 10% total body weight loss matter? So there was a very strong belief that if you get to that weight loss through a procedure like Rowa gastric bypass, the benefit on metabolic profile is different than if you get to this with a procedure like a sleeve. And there's a recent study that challenged this concept. 2 studies, actually. One in animals and then one in humans. The animal study shows that when they compared a Rowa gastric bypass to a concept of intragastric balloon with intestinal liner in rats, you could see here that the weight compared to sham is similar improvement with both the Rowa gastric bypass and sleeve balloon combo. When you look at visceral adipose tissue, you could see that the improvement in visceral adiposity is similar. When you look at blood glucose profile and plasma insulin and GLP-1, it's all similar between the 2 groups. But the 2 groups have different mechanism of action. Now, if you look at resolution of fatty infiltration in the liver and in the skeletal muscles, you could see that both groups had significant resolution of excess adiposity in these organs. What's interesting about this paper is if you look at the sleeve balloon combo in figures A and B, and you look at the emptying of the stomach, you could see that the majority of the radiolabeled meal is still in the fundus with the sleeve balloon combo endoscopically. If you look at the gastric bypass cohort, you could see that there's very little sitting in the gastric pouch and there is rapid emptying into the small intestines. So two procedures working differently physiologically led to the same improvement in metabolic profile. This was confirmed in a hot off the press article that looked at the effects of diet versus gastric bypass on metabolic function in diabetics. And this was just published in the New England Journal of Medicine. And what's interesting here is they took two groups, they matched them prospectively to lose the same amount of weight, whether with a restrictive diet or whether a gastric bypass. So you could see that both groups had similar improvement in body mass index from 42 to 35, and the surgery group from 33 to 35. That correlated to significant decrease in visceral adiposity. This is in grams. You could see 23 grams to 14 grams with the exact same improvement in the surgery group as the lifestyle group. If you looked at intrahepatic triglyceride content, same improvement. And then if you looked at insulin parameter, glucose, insulin, glycosylated A1C, all parameters improved to the same level. So this study really challenged the concept that, is it about the weight loss? Does it matter how you get there? Or just the key should be, how could we get people to lose 10% of their body weight loss to get to these metabolic benefit, regardless of what procedure that you're using? And there's nothing magical about any procedure that we're having other than it leads to a durable and sustainable weight loss. So therefore, now we're at the phase where we should argue that we should have a spectrum of care, and the goal should, how could we get people to lose 10% total body weight loss, stratified by the severity of their obesity. That means if you have BMI above 40 or above 35 with comorbidity, you should start with surgery. If you have lower BMIs, you should start with endoscopy. If you're in the overweight category, you start with lifestyle and medications. So here's the space occupying devices. You all know about intragastric balloon. There's this transpyloric shuttle, and there's this full sense device that mimics the effect of a lab band by activating the afferent vagal nerves to the brain, independent of food. And as a group, if you looked at US randomized controlled trials, these are the active treatment with these space occupying devices, and this is the sham or controls. You could see as a group that the majority of patients who are subjected to these devices reach this 10% total body weight loss. So it seems that a device placed in the stomach could now improve what a lifestyle modification or medications could do alone and kick us to this 10% total body weight loss. Now there's the endoscopic sleeve gastroplasty that really started in the 2013 era and now has been used across the globe with more than 15,000 procedures done to date. And now we're taking this weight loss and now extending its durability and its magnitude. This is the published literature of the endoscopic sleeve gastroplasty based on 1,700 publications. That's as of last year. Now I think there is more than 2,000 patients, or actually more than 3,000 patients in published literature. But you could see that the total body weight loss at 12 months is reproducible at 17%, with a low SAE rate at 2%. So with endoscopy, it seems that we could get the majority of patients to lose significant weight loss that results in metabolic improvement. Now, mind you, this 17% weight loss is the same weight loss as in the New England Journal of Medicine that showed the resolution of most of the comorbidities attributed to obesity. Now, 5 years follow-up, endoscopic sleeve gastroplasty is better than space occupying devices, because you could see this is from Reem Sharaiha and the Cornell group. This is 203 patients that were followed for 5 years, and the durability of the procedure at 5 years is good for endoscopy standards. So then if we go and say the goal is to reach 10% total body weight loss, regardless how you get there, the patient does not care about average weight loss. When we report average, say this cohort has this average, the patient wants to know what's my chances of reaching 10% total body weight loss if I get one procedure or intervention. And you could see here I staggered all the trials that include lifestyle intervention, medications, bariatric endoscopy, and surgery. And you could see that the spectrum could be nicely filled with all these procedures. And they're all complementary, and they all should be used to manage the disease, because right now we're only managing 2% of people inflicted with that disorder. So as far as to go back to the crux after I built the story about what's the current consensus who we should offer bariatric endoscopy for, I will go back to the joint statement by the American Society of Gastrointestinal Endoscopy and ASMBS that put together the task force to evaluate this question. And I read from the task force recommendation: based on available evidence and expert opinion, the task force recommend that an endoscopic bariatric intervention intended as a primary obesity intervention in class 2 or 3 obese individuals with body mass above 35 achieve a mean threshold of 25% excess weight loss at 12 months. And as I showed you, most of the intervention available right now reach that consensus. So per the guidelines, these procedures should be preserved for individuals with BMI above 35. They did not define an upper limit of normal, but it's I would extrapolate that it should be class 2 or 3 obesity, and more severe obesity should be offered bariatric surgery first. If they do not opt bariatric surgery, then they could get a less invasive option. In clinical practice in the United States, with balloons and endoscopic sleeve gastroplasty, the BMI have ranged between 27 to 45 in the majority of patients where these procedures are being applied. Now, if we go outside of the US and include the Brazilian consensus, that included 47 Brazilian endoscopists with 1,800 endoscopic sleeve gastroplastic procedures and a total body weight loss at 18.2% at 12 months with an SEE rate of 0.8%. They recommended that the ideal BMI for these procedures is 30 to 35. So they went lower than what's recommended in the US. And they said that the minimum is a BMI of 27. And I would argue this should be even lower for an Asian population. And they did not define an upper limit of BMI, but I would say that severe obesity is still, the bariatric surgery is the gold standard, and you only offer these interventions when you have somebody with a BMI above 40 or 35 with diabetes. You should only offer these interventions if the patient refuse bariatric intervention. So the absolute contraindication based on this consensus is active ulcer disease in the body or the fundus, congestive gastropathy, gastric polyposis, gastroesophageal varices, uncontrolled or untreated psychiatric disorder. So for the intragastric balloon, since there's multiple manufacturers with different designs, it's very hard to put inclusion-exclusion criteria other than refer to the instruction of use by the manufacturer. But in general, it's a similar BMI as ESG. Don't offer a previous esophageal or gastric surgery of any kind, including a simple PEC2 placement. Don't offer if uncontrolled or unmanaged psych disorders. Don't offer to patients with gastroparesis because they will develop gastric atony and they could perforate their stomach. So these are in general the guidelines. Now we're going to just shift gears for the last couple of minutes and talk about weight-independent metabolic benefit that should not be tied to a particular BMI. And these are interventions that are being developed on the small intestines that will target insulin resistance, dysbiosis, inflammation, and bile acid signaling that could be applied independent to BMI. And what we're talking here is intervention mostly working on the duodenum. As you all know, the duodenum is an important regulator of metabolic function and inflammation. And the reason the duodenum is a target, because we know in states of insulin resistance and metabolic disease, the duodenal interaction with key metabolic organs like the liver, adipose tissue, pancreas, and peripheral muscle is altered. The duodenum becomes leaky, and it translocates mediators of inflammation to the portal circulation and causes visceral fast dysfunction and inflammation. So the duodenum has been a target independent of weight for metabolic benefit. And here's some of the basic science behind what's going on with the duodenum to cause it to become inflamed. One of it is a state of dysbiosis and leaky gut, translocating lipopolysaccharides to the portal circulation, inflaming the visceral fat, leading to the consequences of fatty liver disease and NASH and insulin resistance. But the idea here is we'll have a group of interventions that take a diseased duodenum and reverse the clock on it to become an insulin-sensitive anti-inflammatory duodenum. And this is what's the constitution of the duodenum changing with this reversal. Here we have intestinal liners that bypass the duodenum and causes this physiology to reverse. But also we have ablative techniques, whether using a laser, using hot water, or now the new kid on the block, using thermal ablation with the process of electroporation or cell lysis in order to take a diseased duodenum, resurface it, and have it reverse course. This is the proof of concept study published in our premier journal, Gut, that looked here at people with body mass index between 24 and 40, type 2 diabetes, on stable oral glucose-lowering medications, and they subjected them to one session of this duodenal mucosal resurfacing, and you could see independent of weight loss. There was not significant weight loss in this group, about a 1 to 1.4 improvement in hemoglobin A1C, which is, again, a concept of targeting metabolics regardless of excess adiposity or body mass index. So what about the comment here from the societies? They said we advocate using 5% total body weight loss as absolute minimum threshold for any non-primary, that means early intervention, bridging, or metabolic benefit when we evaluate these procedures. I could say with the newer concept of devices that works on the duodenum, there should be no BMI cutoffs. That means it's not a BMI question that we're dealing with, it's improving metabolic and cardiovascular and liver health. Therefore, the limits of BMI are being challenged. And I would venture and I would personally offer it, if I have a patient with type 2 diabetes, fatty liver, and their BMI is 25, I'm not going to hesitate to offer them one of these duodenal resurfacing intervention because of the pathophysiology that we discussed. And just a time check here. I think I will end here by talking about a quick case that illustrates that there should be no BMI cutoff when you're looking at a bridge procedure. This is a patient that we had at Mayo Clinic with incarcerated hiatal hernia, Crohn's disease, and her BMI was something like 48. So this, given her Crohn's disease, she was not offered a row wide gastric bypass, though in an ordinary situation, row wide gastric bypass would be the procedure of choice in this patient. So here we embarked with our colleagues in thoracic surgery to do a hernia repair with closure of the hiatus, and at the same session do an endoscopic sleeve gastroplasty. Here we're finishing the hiatus repair. And then we are doing the endoscopic sleeve gastroplasty at the same session. Just for the sake of time, because I'm over in a couple of minutes, I will go to the results of this intervention. Here is the sleeve after 6 months endoscopy, nicely intact with an intact hiatus and hernia. And then the patient went from a BMI of 48 to a BMI of 32 with this combined intervention. So you could see there's no cutoff in this case. You use whatever cutoff there is. So with that, the future and these thresholds that I just discussed with you are rapidly changing, because now you're going to mix and match. You're going to have repeatable endoscopic bariatric procedure. You have combinable, you have sequential, and you have enhanced, and you have personalized. So this is what we know, but this is rapidly changing and will continue to change over the next few years. And with that, I will conclude, and thank you for your kind attention.
Yeah, so thank you, Barham. It's a fantastic overview of the big topic which you have concised very precisely. So without wasting time, I move on to and request Professor Gontran to give his expert comments on this. I think Barham has given the overall view of what's happening in the field of bariatric endoscopy. And Gotran, so can you give your expert comments on this, probably what you feel, because you also do a lot of research R&D on this kind of devices, and what is existing already. Over to you, Gotran.
Well, it has been a real pleasure to listen to my colleague and friend, Professor Abudaye, because as a very good demonstration of exactly the point where we are at this moment. So I think we have advanced a lot in the field of effectiveness and safety of those procedures, but we needed these last 5 years to demonstrate also why we have to increase the penetrancy of all of these treatments. The problem has been that most, and it's still the problem, most of the obese population of those patients are still with no treatment at all. We have to demonstrate and we have to make a very big effort in communication, in media, telling them that the needings of losing 5%, 10% of total body weight loss, it's mandatory for their health, cardiovascular, metabolic, and fatty liver disease health. This is the moment and this is the era to offer the patients what Barham has been showing us. We can offer them non-invasive procedures, quick procedures, very easy to demonstrate what we are. So the moment is not to talk anymore about safety and effectiveness, because I think that with the total body weight loss in 80% of the patients, around 10%, 80% of them are good responders. Maybe we can enter in two fields. One field is making the effort to communicate this, not among doctors, but also to the patients, increase the necessity of these treatments. It's mandatory, but also among doctors. I think our role now is trying to understand or work in personalization of those treatments, identifying good responders, identifying how the combination with lifestyle, medication, and endobariatrics can enhance the results. And also, it's a very good moment, and we have been working in Madrid and Rochester Mayo Clinic with Barham's team in personalization, for example, of these treatments based on physiology. If we can identify those patients with a more likely responders to those treatments, or identify those patients who are going to be intolerant to these patients. We have to know that how frustrating it is for our patient if they are very encouraged with an intragastric balloon, a very simple device and very simple treatment, but if we have to remove it because of intolerance, it's frustrating for them. But so we have to work trying to identify those who are more likely to respond and those who are more likely to be intolerant. And also is the moment, is the era, as Barham has shown, to trying to combine everything we have. Everything we have now is lifestyle intervention with different strategies, medication, and different bariatric endoscopy procedures based on this physiology algorithm that we can do. So I have really enjoyed Barham presentation because has shown us exactly the point what we are in endobariatrics, which has not been easy because 10 years ago, bariatric endoscopy was almost a baby growing, but now we are here debating with the biggest gold standard procedure, which are the surgical ones. So I think we have seen here that we are moving forward and advanced. That's my comment.
Thanks, Gotran, for that very elegant comments and suggestions. So without wasting time, we'll move on to the next lecture by our surgical colleagues, and then we'll come back to you and Barham for more questions from us and the audience. Abhishek, can you just
even I have got a lot of questions for Barham and our endobariatric colleagues, but I would like to keep it for the end. Meanwhile, we'll go to Dr. Omar. He is a bariatric surgeon from Mayo Clinic, and he will be presenting about choosing the optimal procedure in the bariatric and metabolic surgery. Meanwhile, Dr. C.K. Huang has also joined us from Taiwan. Welcome, Dr. C.K. Huang.
Hi, everyone. How are you? I'm here.
Omar's presentation.
Thank you. First, I would like to thank everyone for the invitation. It's an honor and a privilege to be part of such an esteemed panel. My topic today is going to be bariatric and metabolic procedures, choosing the optimal from a laparoscopic point of view. No disclosures. First, I'm going to start by discussing the Mayo Clinic data. This is from 2019. We do a fair number of primary bariatric procedures, bypasses, sleeve, and duodenal switch. But what really makes our program different is the high percentage of revisional surgery, complex revisional surgery, which is about 30% of our practice compared to about 14% nationwide. So bariatric procedures, when we say the optimal procedure or the best procedure, are we talking about the traditional procedures, bypass, sleeve gastrectomy, duodenal switch, band, or are we gonna go into the details of the many novel and popular procedures that were thoroughly discussed by the paper of Phoebe, Higa, and Garnier in the Bulletin of American College of Surgeons, like mini-gastric bypass, SADI, SASI, banded gastroplasty, bipartition, and others. Also, when we discuss bariatric, the optimal bariatric procedure, are we taking geography into account? Because the IFSO Global Registry report in 2018 showed that different countries have different preferences for procedures. Although our patients are similar to some extent, although the comorbidities are similar, still different countries have different preferences for performing bariatric procedures. So for the sake of this discussion, I'm going to be focusing on the procedures that were endorsed by the ASMBS, on the procedures that are covered by the American insurance and that we do here at Mayo Clinic. We don't do adjustable gastric bands since 2011. We mainly do bypasses, sleeve gastrectomy, and duodenal switch as part of our practice. And again, when we talk about the optimal procedure, as mentioned by Barham, there is many factors, but the first thing that comes to our mind is efficacy. However, if this was the sole determinant of the optimal procedure, we should be doing more and more duodenal switches, as it is known to be the most potent bariatric procedure. But when we look at the ASMBS data, less than 1% of the bariatric procedures performed nationwide is really duodenal switch. So there must be another factor that we're looking at, and this factor might be risk. If we plot on the graph efficacy versus risk, we notice that from a bariatric procedures point of view, or standards, the more efficacious or potent the procedure is, the more risky it is. So band, then sleeve, then bypass, then mini gastric bypass, then duodenal switch. And this explains why duodenal switch, although it's very potent, it's not that much practiced or performed, and mainly it is because of the risk that it has associated with it. So again, weight loss or efficacy, are we treating the patients that come with initial BMI, different initial BMIs the same? Are we talking about the target BMI or weight regain? When we talk about risk, are we talking about the peri-op risk, long-term, or the quality of life? With weight loss, do we treat the patients that come with a BMI of 90 the same way we treat the patients that come with a BMI of 30 or 27? So choosing the optimal procedure depends on the initial BMI. Do we mention weight regain for the patient? Most of the time we tell them sleeve and bypass are equivalent, but this is with weight loss. Do we mention weight regain to the patient? Do we include them about the weight regain concept? I'm going to discuss first the initial BMI. Roux-en-Y gastric bypass versus gastrectomy was studied in the super obese individuals above 60 BMI and super obese above 50. And Roux-en-Y gastric bypass was found to be superior in this patient category at 12 months. Also, duodenal switch, randomized controlled study, JAMA surgery 2015, 5-year data in BMIs above 50 or 50 to 60. Also, duodenal switch was found to be superior to Roux-en-Y gastric bypass when it comes to BMI drop, 22.1 versus 13.6 at 5 years. So we can safely conclude in this patient category that duodenal switch is more potent than Roux-en-Y gastric bypass than sleeve gastrectomy. As for a weight regain, This is again not much highlighted on in literature, not much studied, but the Indian Bariatric Surgery Outcome Reporting Group, including Dr. Mahawar, published this recently in Obesity Surgery 2019, where they checked weight regain for multiple procedures, and they checked the 5-year data. And this study showed that sleeve gastrectomy has about 35% weight regain compared to Roux-en-Y gastric bypass, which is 14.6 weight regain. I excluded the mini gastric bypass and just for the sake of this discussion, but again, Roux-en-Y gastric bypass is superior to sleeve gastrectomy from that aspect. Adverse effects, again, peri-op, leak, bleeding, and the many issues that can happen peri-op or long-term, ulcers, internal hernias, or GERD with the sleeve, or nutrition deficiencies with the switch. Are we including that when we choose the optimal procedure? And this is a randomized controlled trial from JAMA Surgery 2018, the famous SMBOSS trial. And this compared sleeve and bypass. And this showed that the reintervention rate with sleeve gastrectomy is 15.8% compared to bypass, which is 22.1%. So again, we go back to the efficacy versus risk curve. And this shows that the more efficacious the procedure is, the more complications there are. Also a meta-analysis and systematic review compared sleeve and bypass, and the early major and minor complications were less in the sleeve when compared to the bypass. That said, when we include the concept of quality of life, they were found to be equivalent, and part of it is because of the reflux that comes later with the sleeve gastrectomy, and that is affecting the quality of life. So again, complications and risk may not be equivalent to quality of life when we introduce that to the equation. So we talked about weight loss or efficacy. We mentioned adverse effects or risk, but that is not the sole determinant. These are not the two sole determinants when we choose a bariatric procedure. We have two other factors that come into play: comorbidity control and patient factors. When it comes to comorbidity control, some patients come to us and say, I just want to have my diabetes under control. I don't care about how much I lose, for example. Same for patient factors. Are we taking in this fact that patient's age, medications, complex hernias, comorbidities into account? And then we'll start first with the comorbidity control and talk about diabetes and show what or highlight on what the data shows. This is a very recent study in JAMA Surgery, a PICORNET study, and they compare sleeve and bypass. Patients with bypass had slightly higher diabetes remission, less diabetes relapse, better long-term glycemic control than those that underwent sleeve gastrectomy. When I'm choosing the optimal procedure based on the diabetes only, I always quote the Annal of Surgery paper by Aminian and Schauer that has the individualized metabolic surgery score. It shows that in mild disease and moderate disease, bypass is superior. In severe disease, bypass was the same as sleeve. This is because the beta cells are depleted. And for this category of patients, sleeve is recommended mainly because it is less risk and it has the same efficacy or resolution of diabetes. So this is the score. It's an app that you can download. You introduce all these variables and then you calculate, and then you come up with this recommendation that tells you, for this patient, if diabetes is the main issue you have or the main problem you're trying to control, this is what we recommend based on that. Again, the other comorbidity control or comorbidity I'm going to discuss is NASH. This was extensively discussed, a randomized control study in Annal of Surgery 2017. With patients of NASH, if we look at that alone, sleeve was shown in those two studies that to be equivalent to bypass when it comes to NASH resolution. Even if we look at the cellular level, and his colleagues looked at the pathology, pathologically, and they showed that sleeve and the bypass are similar when it comes to NASH control. Reflux, this is a third topic I'm going to highlight on comorbidity control. It is prevalent in our patient categories, and although the study is not a randomized controlled or a meta-analysis, but it was a very influential and now affects majorly our decision making when we make these decisions on choosing the optimal procedure. The Genco a study that showed Barrett esophagus to be prevalent 17.2% after sleeve gastrectomy. Same in the SMBOSS. This study showed when we look at reflux that the bypass is the optimal procedure compared to sleeve for a patient with reflux, if we're looking again at just GERD or reflux to control that comorbidity. Our group here at Mayo Clinic, Barham is the lead author on this paper, checked esophagitis after bariatric surgery, and erosive esophagitis was shown to be more prevalent after sleeve gastrectomy than in low gastric bypass, although this was a bit surprising that we did have a decent percentage of patients with erosive esophagitis after Roux-en-Y gastric bypass. So again, for GERD, it is a no-brainer for me that bypass is superior to sleeve if we're looking at the comorbidity control for this category of patients. When we look at patient factors, there is multiple things to look at before, again, getting into the optimal procedure. Patients with complex past surgical history or complex hernias, if they are smokers or not, if they are compliant or not, age, future transplant, and I'm just going to highlight on certain topics of this just for time. Age was studied without a question, sleeve in a meta-analysis and systematic reviews. This was both 2020 studies in obesity surgery. Patients above 55 or 60, sleeve is safer than the bypass in this category of patients. Also, I'm going to highlight on future transplant candidates. I kept this blank because there is really no good comparative studies for future transplant candidates. There is paper by Moore, there is paper by Heimbach, Rosenthal, the Mayo Clinic data by Heimbach. Again, it shows that for liver transplant patients, it shows that sleeve gastrectomy is safe, but it doesn't really compare sleeve gastrectomy to bypass. These studies were just saying that this is a feasible option to get patients to transplant. My preference for this category of patients is to perform sleeve gastrectomy for the many reasons. One, no change in anatomy at the time of surgery, and also the fact that they're going to be on multiple medications, immunosuppressants, steroids. We don't really know how this affects our absorption and the medication absorption, and if this is going to predispose to relapse or not, just because again these medications are not well absorbed. So looking at this, we have weight loss, we have adverse effects, we have comorbidity control, we have patient factors, and when they all intersect, or where they all intersect, we think we figured it out. Okay, this is the perfect or optimal procedure. But what we forgot is that patients have their own opinion, and they come sometimes to you and tell you, I don't want a bypass, no matter what you recommend. I don't want a bypass or a sleeve or duodenal switch. So how can we make this an objective thing? The patient's opinion, how we can make it objective, or as objective as it can be. This is the MBSA QUIP Bariatric Surgical Risk Benefit Calculator. You put the information in. This is available on the internet, and you get these graphs where they compare band, sleeve, bypass, and BPD-DS. If we look at this, it compares death, complications at 1 month, leak, bleed, and then here, if we also look at the 1 year BMI, it shows how things change. Also, we have the 1 year comorbidity remission. So here the patient now can make an educated decision with you as a surgeon of what is the optimal procedure for this patient specifically. And then the patient would be part of your decision making and within that circle where everything intersects. My personal algorithm, I offer sleeve gastrectomy patients for patients with extreme ages, either that are very young for compliance issues or for the older patients for safety issues. For patients with BMI above 60 as a first stage procedure, patients with concomitant complex hernia that have bowel in it, high-risk patients, CHF, chronic renal failure, again for safety issues. Just this is a 20-minute procedure or 30-minute procedure skin to skin, so it's kind of safer than the longer bypasses, less complications afterwards. Patients who are on NSAID steroids, poor compliance patients that, for example, are ex-smokers and they don't know if they're going to go back or not after the surgery, I offer them sleeve gastrectomy. Who do I offer duodenal switch for? Patients with BMI above 50, age 18 to 50, compliant, sorry, this is a typo, not complaint, compliant patient, ability to afford vitamins and frequent testing because these patients require close follow-up, absence of osteoporosis, nephrolithiasis, or Barrett's. Patients with diabetes that are young, I tend to offer them the duodenal switch because these patients will relapse less with time. And patients with malrotation because of the anatomy, and we perform the duodenal switch mainly on the right side of the belly. So these patients are easier. Duodenal switch is offered to this patient category than the Roux-en-Y gastric bypass. Everyone else gets a Roux-en-Y gastric bypass. This is the bias that we have. I have, and unfortunately, I talked about all these factors, but the main bias that you cannot also make it objective is the surgeon's bias. With this algorithm, I do about 65% bypasses, 30% sleeves, and 5% duodenal switch for primary bariatric cases. And I say everyone else gets a bypass because I was trained at Mayo, and we are biased for Roux-en-Y gastric bypass for a good reason, for our anecdotally with our patients and from a data standpoint. So I go into the patient, and in my mind as a surgeon, I want to shift the discussion one way or another to introduce my clinical judgment of this case into the discussion, or to unconsciously convince the patient of what is the best procedure for them sometimes. This is because these patients come to you and they don't have just one thing to control or one comorbidity to work on or certain BMI. I give an example, a patient who is a smoker and at the same time has bad reflux. We don't operate on smokers, but if we make them stop for 1 year or 6 months or 3 months, we know that there's a high probability they're going to go back to smoking. So what do you offer this patient? If you offer Roux-en-Y gastric bypass, you're going to end up with ulcers, 8 to 12% ulcers, if not more, with smoking. If you offer them sleeve, reflux is going to worsen. So this is when you use your clinical judgment as a surgeon, and going into the room, you know that you are biased. So is there an optimal procedure? No. I used to say there is no perfect procedure. Then I evolved and started saying, well, there is the perfect procedure for the perfect patient, there is the right procedure for the right patient. Also, I evolved and I say now, there is no perfect procedure. You go into the room, you listen to the patient, you look at their comorbidities, you ask them what do they want to achieve, and what applies to that certain patient in that certain period of time, that period of their life may not apply to that same patient in another time with a different surgeon. Thank you.
Umar, for wonderfully covering all the aspects, including the algorithm which you have told. And in fact, the reason I invited two expert panels in bariatric surgery, the reason being Dr. Kamal Mahavar has done an extremely wonderful publications and has done a lot of research on OAGB, which is not being done as compared to other part of the world in US. On the other hand, Dr. C.K. Huang, who is an inventor of a modified BPDS procedure, which is loop duodenojejunal bypass with sleeve gastrectomy. So we call it sleeve plus procedure. So everything has been covered by Dr. Omar as far as the part is concerned, but the OAGB and the sleeve plus procedure which are missing. So I would like Dr. Kamal to have give his expert words on OAGB, followed by Dr. C.K. Huang to enlighten us about sleeve plus procedure. Thank you.
Sorry, before you start, I knowing that I'm not going to elaborate on MGB, knowing who our panel is, I was comfortable with that, knowing that both you can cover this aspect. I did not feel that this is fair for our people who are listening and the surgeons who are listening and our audience, for me not performing MGB and giving or loop DS and giving some data on it. I know that both of our panelists are leaders in this field and can give that as well. Thank you.
Thank you. If I may, so first of all, it has been Absolutely wonderful to listen to Professor Abudaya and Dr. Ganam today. I have to say I've learned so much, and I think it justifies attending the webinar after the busy night on call. I'm honored, and I've learned so much. Now coming to this, because you see, obviously, we are looking after a large population of patients suffering from obesity and metabolic syndrome. And there is no one size fits all. And I think the first thing that we all have to think about is bring the focus onto the disease and not the procedures itself or one treatment or one thing. Because if the disease is in focus, we'll be able to help more patient groups. And that is where we as clinicians need to follow the data, develop more things, and look at helping more and more people. And then everything else is artificial, medical treatment, endoscopic, surgical, these divides are artificial. Historically, patients have always been helped better when we have worked together. Otherwise, I would still be doing enterectomies and truncal vagotomies, and there will be no PPIs, you see, because surgery often finds the right model for other developments to then take place. And let it be so for obesity surgery as well, or for metabolic surgery as well. I think with regards to endoscopy, first of all, my take is that it is a great field. It is obviously the future. And I think things are happening at a remarkably rapid pace. We will need to develop safer and safer strategies and develop long-term data on that. I was personally surprised to see the long-term data on ESG. I wasn't aware of that, and I think it will intrigue me more to find out more about this. And I think things like that will drive things forward, because the complication rate with endoscopic interventions is going to be lower than the surgical interventions. We know that sleeve gastrectomy sometimes has fatal complications, whether it is leak or whether it is portosystemic venous thrombosis. We know that they can be life-altering. And if the same outcomes can be delivered by something safer, I would personally have it, and I think my patients would. Now, coming to surgery, which is my main area, I am a little bit, I think, in a slightly advantageous position compared to Dr. Gannon, because I offer one anastomosis along with Roux-en-Y gastric bypass and sleeve gastrectomy to my patients seeking primary bariatric surgery. We do not offer BPD or DS in our unit, and I think by and large in the United Kingdom, very few surgeons would offer that as a primary bariatric or metabolic procedure. Again, we could discuss the reasons for it, but I think, we're all trying to find the optimum surgical procedure which balances the risks and offers our patients the maximum benefit. If we knew the answer, if there was one answer for every patient, I think we would have had it by now. So the reason we're talking about all these things, it tells me two things. A, that there is no one answer, and maybe there can never be one answer, because patients is not just one category, because we're dealing with a very heterogeneous cohort of patients that have a number of problems and expectations and life circumstances. So I don't think there will ever be one answer to all our patients. Having said that, data is becoming very rapidly clear that weight loss is what determines the outcomes, the metabolic outcomes. Professor Abudaya cited the NEJM paper, and there have been other papers published by where I live by Professor Roy Taylor in Newcastle. He's published some path-breaking work on that, and the data is coming out that the previous belief that we do something with the bowel and hindgut and foregut and all that is important maybe in sustaining the weight loss, but once the weight loss is delivered, the outcomes are similar to weight loss achieved through other methods. And I could not agree more with that. I think the only thing that we think about is that surgery may be offering more durability, and how is that coming? We need to look at that in future. So because I offer these three procedures in my private practice, in my practice, I think I'm able to follow a slightly different algorithm. For example, when you are saying that for patients who are suffering from higher degree of obesity, let's say BMI more than 50, or higher degrees of metabolic syndrome, let's say type 2 diabetes, you obviously, when you're choosing BPD-DS, you're trying to choose a stronger procedure for them. You're trying to find something which gives them a better chance at the disease or metabolic syndrome. And we know from our own meta-analysis of 5-year outcomes comparing RYGB and sleeve gastrectomy that RYGB offers superior weight loss and superior but statistically insignificant difference in metabolic outcomes as well compared to sleeve gastrectomy at 5 years. So we know that gastric bypass offers more benefits in the longer term, and BPDDS, as you quoted, has higher chances. But what I do personally in most of these patients who have this higher disease burden of obesity and metabolic syndrome, I offer them one anastomosis gastric bypass. It allows me to reduce the surgical risks because the PDDS, surgeons know, is not an easy procedure. I offer them a procedure which is actually easier than even Roux-en-Y gastric bypass. It takes me 30 minutes less to perform. Easier for me, I tell my patients, is safer for them. Because if I'm struggling, they are paying a price for it. So I do a procedure which is simpler, easier for me, for patients with a heavy burden of disease. That is my personal preference. I think you could do any procedure, and as long as your results are okay, I think that's justified. I'm just sharing what I do. For patients with lesser burden of disease of obesity or metabolic syndrome, I prefer to counsel them to have a sleeve gastrectomy. And again, we go with patient choice as well, and there are many factors. And when it comes to patients with significant reflux, and I'm talking about patients requiring, daily PPI or evidence of erosive esophagitis on endoscopy, those patients, my bias is, I speak to them and I say, look, reflux is a dominant feature in your life, and if you want treatment for that alongside treatment for obesity, then maybe you should accept the higher risks of Roux-en-Y gastric bypass, and we offer them a Roux-en-Y gastric bypass. But in patients with BMI more than 50 or 60, where we know that Roux-en-Y gastric bypass can be very challenging and associated with a higher complication rate, I counsel them to have a one anastomosis gastric bypass, being prepared that they may have a higher rate of conversion to Roux-en-Y in the future. So I say, look, you may have a higher rate of conversion, but I'm offering you something simpler and safer now, because, we are very proud that in our unit, we have a 30-day mortality of 1 out of 5,000, and we want to keep it that way. Because safety is in our unit a key determinant for outcomes, and we don't want to compromise on that. So that is my philosophy, and I'm not saying that is the only philosophy. And I agree by and large with everything that's been said by Dr. Ganam and Professor Abhidaya. Thank you for the time.
Thank you so much, Dr. Kamal. Dr. C.K. Huang, you do a lot of sleeve plus procedure, and I know that you don't do much of OAGB, and I haven't seen any during my tenure with you. So what is your opinion about, and what is your expert opinion on that?
Okay. First, I want to thank Dr. Faham and Omar's talk. I really appreciate, and I learned a lot from you too. In fact, I think till now we have, from endoscope to bariatric surgery, it has been very, very variable procedure right now. And before, when I go back to my history, 15 years ago when I start, that time we have only Roux-en-Y bypass. After 5 years later, then sleeve gastrectomy become the main dominant procedure now. But then everybody in Asia start to abandon the Roux-en-Y bypass. So now the number of Roux-en-Y bypass in Taiwan, according to the society data, showing the Roux-en-Y bypass has been less than 20%. And another bypass like OAGB in Taiwan accounts only about 5%. So sleeve has become the main dominant procedures. For me, the same, 10 years sleeve gastrectomy, but now we see more weight regain and some reflux issues. So nowadays, Roux-en-Y bypass has been slowly abandoned because of we see a lot of marginal ulcer in Asian patients. In our data showing there's about 20% marginal ulcer. In that, about 10% is symptomatic marginal ulcer. So the smoking issue and the marginal ulcer issue is one of the reasons why we need to slowly abandon these procedures. But because of we also see the same data from Omar that in the diabetes remission in those with higher BMI, in fact, sleeve gastrectomy is not enough for achieving a good weight loss and including the diabetes remission. So we start to think about the sleeve plus some bowel bypass might be a good options. But as you see the duodenal switch, in fact, it is a very efficient procedure, but it carries a lot of malabsorption issues. For Asian, we don't have much super obesity patients. So when we consider those who BMI maybe 35 to 40, the patient don't have very good control diabetes, or even the patient is poor pancreatic function. If you want to offer the procedure for that, then root bypass might be one of the options. But if you consider the patient's long-term problem from the dumping syndrome, marginal ulcer issues, we might consider another procedure that having the weight loss and have less malabsorption compared with duodenal switch. So no matter it's duodenal jejunal bypass plus sleeve or jejunal bypass plus sleeve, in fact, it looks like a very efficient procedure according to our 5 years data recently will be published. So I think for Asian groups, this is a very viable procedures and a good options for us. But I think in Europe and Western country, you still don't take this as one of your options. And in my own practice till now, in fact, have been about 60 to 70% become sleep plus procedures. Sleep alone costs only about 30%. Bypass itself less than 5% already. So I think because right now is just two speakers talk, I think the patient's factors, the surgeon's factors, the patient's comorbidity, the gastrointestinal condition, in fact, are all the factors we need to consider. But I think because of the procedures always changing every decade, so according to these kind of findings, including all the meta-analysis, in the futures, I believe we would have some even newer procedures to offer to our patients. But the patient's decision is still one of very important factors. Just now, everybody talking about patients need to make decision with us. In myself, I also do the same. So we cannot say you want the bypass, then I offer you bypass. But if you want the bypass, I need you to talk to you about the risk and what problems can have. If you want to sleep, you might need to understand the reflux issues, you might have the weight regain issues or poor diabetes outcomes in the long term. So you might need another revision of surgery in the future. So I think this is the way how we need to discuss with patient and make them to have a good insight on this. Okay.
Thank you so much, Dr. Huang. We have few questions. For the first question, I would like to ask Dr. Barham and Dr. Lopez. Dr. Barham, you spoke about resilient guidelines, which you covered in your talk. So I want to know whether GERD and hiatus hernia are contraindication for ESG or not.
So for ESG, again, our thinking about its function and what it does have changed, or as we learn more and we investigate the physiology of this procedure. And initially, we were very worried about GERD, extrapolating from the same data that we have for sleeve, saying it's going to be a lower, a smaller stomach with higher pressure system. But then we start doing some of the studies, including scintigraphy, including functional MRIs, and including physiological testing. And we realized that it's not truly a high pressure system because the stomach is still fully innervated. If you look at the functional MRI, which I have not shown but will be publishing soon, its peristalsis is completely intact, and the angle of His and the accommodation of the fundus is still there. These are important anti-reflux physiological mechanisms that are not being altered by the endoscopic sleeve. To the level now that we do not even worry about giving patients PPI, and we just follow them for symptoms. And so far, the data have shown that reflux is not an important factor or a complication of endoscopic sleeve. On the contrary, reflux improved by decreasing abdominal adiposity. Now, the issue of hernia becomes more important if you are wanting to decrease the reservoir of the fundus more significantly and the risk associated with this procedure. But what we usually say, we used to say no hiatal hernia, but now I accept patients with a hiatal hernia up to 5 centimeters for the sleeve, because I know that the reflux is not getting getting worse, at least in the data that we have so far. that's where we are, and we're continuing to learn along these lines.
What is your opinion, Dr. Lopez, on this?
Well, I cannot be more agree with Barham, but maybe I would like to highlight something for the audience understanding. The aim in endoscopic sleeve gastroplasty is to delay gastric emptying, which at the end is creating longer time of gastric retention of the food. That's the key point to avoid, to decrease hunger and increase satiety. With more time with the food inside the stomach, this will tamper the acid, so we can see clinically that patients decrease the needings of PPIs in those where we found, for example, esophagitis B at the moment of the procedure. For example, now, if we find pre-procedure esophagitis B, we treat them with PPIs, but we do the procedure because we know that the evolution of this esophagitis will go to healing. So ESG helps healing this esophagitis, so I think it's not a contraindication at all. And I understand it's more difficult and has to be individualized with patients when we are talking about hiatal hernia. We have to measure and see the whole anatomy. This is different. But with GERD, we move forward and we do the procedure.
One thing I would add about the GERD question and even hiatal hernia is that's where the anatomy preserving function of these endoscopic procedures becomes important. Because what's the risks? Patient develop reflux, you reverse the procedure. And they will go back to a normal functioning open stomach and go back to square zero. So you have not burned any bridges into either future bariatric procedure or just reversing the anatomy that led to the complications to begin with. So that's where they hope, that's where when you take a population-wide strategy and you want to apply these interventions to the mass population where even a small percentage of the complication will be magnified as far as burden to society and healthcare systems, this function that you could reverse this with little or no consequences is an important part of the decision making as well.
Thank you so much.
Yeah. So I think the time constraint. So I just want to put one question to the surgical panel. It's a very basic question. So obesity with diabetes, standalone obesity. So as of now, and the other scenario is a motivated person and a not motivated person. So the main reason what we all are struggling on is a weight regain. So in that scenario of a weight regain, in simple words, just to have a take-home message, what is your preference from the surgical point of view? I know it's again mild, morbid, moderate obesity. There are different ways of approaching it. But what my question is, in a patient who is having a motivation for weight loss and sustaining it, and in a patient who doesn't have a motivation to weight loss, kind of a binge eater, what are the surgical options you give? Because there are so many, I agree, it's very difficult to wrap up in a single thing, but still I just want to have an overall view of all the three experts and then give us it's a small niche of the guidelines.
This is a patient who already have underwent a procedure or no?
No, I mean to say a patient who wants to get a procedure.
Primary procedure.
Yeah. Again, I have to say that I'll go back to the same algorithm. Unfortunately, if I have a binge eater or a non-compliant patient, that patient should not be getting surgery first. That should be counseled for a long time. And unless the patient is compliant, you're just giving them the tool and they will not use it. Whatever the procedure is, it's just part of the puzzle. And unless, this is why it's a multidisciplinary working group. We have the endocrinologists, we have the bariatricians, we have the bariatric endoscopists, we have surgeons. We all sit together, especially with these difficult cases, and choose what is the best thing. And we always start in these non-compliant patients with starting with the psychologists and the nutritionists to get them to be more and more compliant. I have a tendency myself, if a patient is, in most of the patients, to not rely on the sleeve, as Dr. Mahawar said. We are seeing more and more weight regain with the sleeve gastrectomy, But at the same time, just to be fair, the beauty of the sleeve is that it can be revised to anything. So although it is not giving us what we want from a surgical standpoint, it doesn't burn any bridges, barely any bridges. You go back, you can change the sleeve to mini-gastric bypass, sleeve to duodenal switch, sleeve to Roux-en-Y gastric bypass. This doesn't apply at the same risk, I'm saying, doesn't apply to the malabsorptive procedures, including Roux-en-Y, mini-gastric bypass, and duodenal switch. So it just falls in the same. It just falls in the same category. Whatever is the patient, compliant, non-compliant, I go back to my algorithm. But first, with non-compliant patients, they need more counseling. Doing any procedure before the patient is 100% in will result in failure. It doesn't matter what the procedure is, because every procedure, you can beat any procedure. It's just how much effort you're going to do as a patient to beat it. Sleeve, you can easily defeat the sleeve, but all procedures, including the duodenal switch, can be beaten. I've seen patients who had get duodenal switch and come back, and you say, did I really do the surgery right? Truly, you go back and review the videos. Well, what is wrong? This patient is not losing what's supposed to lose, because the patient is not investing in the surgery or the procedure you've made. So that is my point.
Thank you.
I would like to address some importance about the compliance. I think that every surgeons and the society agree that all the patients want to come in for the bariatric procedure. They need to understand the results and what they have to follow for the long-term results. But I also agree with that. But I think that I would like to say one important observation recently I found. When the patient need a revisional surgery, if you did not touch the stomach, you just eating some bowel bypass for those who like sleep gastrectomy fail. In fact, after the surgery, the patient would feel very full satiety compared with just having the sleep alone. So what does it mean? It might mean that the compliance and all the motivation are coming from the desire of hormones. We are maybe too much focused on the compliances about the patient's brain function. In fact, it might be from your small bowel function. So if you consider the duodenal switch, why it has better result compared with Roux-en-Y bypass or with the sleep, it might be coming from the different bowel bypass sections and also the how much we need for the common limb. So recent more data showing the bowel bypass carrying more long-term weight loss and also have a better weight loss compared with sleep gastrectomy alone. So here I would just want to address that we should not just forget about the importance of the desire, where it's coming from. The stomach itself and small bowel, in fact, is also very important factors. So we are doing some research about eating some bowel bypass as a revisional surgery without touching the stomach. In fact, it's showing very good result too. So in the long term, we would have more possibility to understand that whether the really successful result is coming from you changing the stomach, also changing the small bowels. So it's a very interesting topic in the future.
Thank you. Dr. Kamal, anything to add from your end?
Yeah, I mean, I think I just want to broaden this debate a little bit. Let's understand that not all patients respond to all therapies. And there are responders and partial responders and non-responders across the medicine, across the whole of the clinical medicine. So I wouldn't pretend to know that we know which patients respond and which patients don't respond, and we know why. Of course, this obesity treatment is a multidisciplinary treatment, and mental health assessment should form part of it. But I'm not saying that mental health epidemic is driving the obesity epidemic. I think these are different things, and we mustn't blame the patients for this, and also be careful about the language we use. For example, some people could criticize us for using the word compliant. We are not talking about a bunch of kids. We're talking about patients suffering from a serious disease. So my bias would be that I would not pretend to know what are the driving factors for for different surgical treatments in terms of responders and partial responders and non-responders in the long term. Having said that, we know that some of this is down to the choice of the procedure. And for that, my bias is when I'm counseling patients, I'm advising them to have a gastric bypass type of procedure, usually a one anastomosis, if they have a higher burden of obesity or diabetes. When they have a lower burden of obesity or diabetes, i.e., using the cancer analogy, lower stage of disease, then I would suggest to them to have a sleeve gastrectomy. And further lower, I would go down with endoscopic or even medical interventions. So that's how I have sort of understood in my head, how this disease could be treated with stage treatment, where we advocate possibly lower risk treatments at lower stage of the disease, and as the stage of the disease progresses, we can give higher risk or riskier treatment strategies. That's sort of my thinking, but it's evolving as the evidence develops. Every year or two we learn, more data comes out, we learn. So I'm hoping that in 5 years time we'll be in different place compared to earlier.
I think sounds very apt. So we have a lot of questions from audience, but because of want of time, so we thought we will conclude it here. Abhishek?
So our surgical director, Dr. G.V. Rao, couldn't attend this meeting because he had to attend a surgical emergency, but he has sent his regards to all the panelists and speakers. And on behalf of AIG, I would like to thank all the societies, OSCE, ELSA, IBC, ESGI, and any other societies who have endorsed our meeting. And thank you all of you, and I would like to ask Dr. Rakesh to conclude this meeting. Yeah.
I think I have to thank all the speakers and the experts taking the valuable time. I know it's so difficult to match the times across the globe. So Dr. Barham, Dr. Omar, Professor Lopez Nava, Dr. Kamal, and Dr. Yong. So thank you all for joining us, and then we will be hoping to see you soon, sometime, somewhere, once the COVID session ends in person, if not again, online again, as usual. Thank you. Thanks a lot.
Thank you.
Thank you. Thank you. And thank you, everybody. Bye.
Bye-bye.
Thank you. Bye-bye.